All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today we have a conversation about how people may or may not change as they adapt with serious illness, which will include some conversations about affective forecasting as well. We are honored to be joined today by Dr. Jody Halpern, who is a professor of bioethics and medical humanities at UC Berkeley, an author, a consultant, a speaker on a global scale, and so much more. But most of all, graciously, she is sharing this morning with us. So welcome, Jody.
Thank you. Thank you, Marty. It's a pleasure to be here. The field that you're all in is the most humanity demanding part of healthcare.
Hmm, Thank you. Our format for today is going to be a bit of a two-way interview. So I've got about 10, 15 minutes to pick Jody's brain about two of her past pieces of work that's kind of relevant to this topic. And then she has the same to pick our brains about that as well. So we are going to jump right in. We're going to start with Mrs. G, and that's from your very first book, which is titled From Detached Concern to Empathy, Humanizing Medical Practice. Jody, would you like me to give the audience a very brief synopsis of Mrs. G, and then we can get your thoughts? That sounds good. All right. So here are my notes. This is what stands out to me. Um, One, we have a person with really significant underlying disease. And for Mrs. G, that's end-stage renal disease and amputations. Number two, she's got a pretty good baseline quality of life. And for Mrs. G, that was mostly sedentary, it was through art, social life. She's got a close group of friends. Three, this person has come to the hospital initially seeking life-prolonging medical care. And in Mrs. G's case, she was going to have her second amputation. So now she's a bilateral amputee. Four, there's an event during that hospitalization that leads to an abrupt 180-degree turn in the patient's perspective. And in this case, Mrs. G learns that her husband is going to leave her, resulting in quite an immediate request from Mrs. G to stop dialysis and be allowed to die. And then lastly, what stands out to me most is this new absolute certainty about how bleak her future now appears to her. Those are what I would consider the key points and certainly patients that we have all seen. And I'll get your thoughts, and then depending upon what you share, I'll pick your brain about some other questions I've got related to Mrs. G.
Well, this case, I was still in training when I met Ms. G. And the case, I mean, it's now decades later. And the case was so upsetting to me and how it was handled that I would say, I've had a very long career writing many different things that have very different foci. But I think the Ms. G case just haunts me and stays with me my whole career because what happened is important, which is the medical team. I was just a trainee, so I talked to each member of the team. I talked to the nurses, I talked to her family, but basically no one listened to me because I was the trainee. I was very concerned about that she was in, having catastrophic thinking. She was in a state of mind of just devastating loss, having just heard that her husband in a long-term marriage in a very disturbing way tells her while she's in the hospital recovering from her second amputation that he's fallen in love with someone else, that he's leaving her. I found this out from her friends who were holding a vigil outside her door. Ms. G was so distraught, she wouldn't let her friends into her room. She wouldn't let anyone say hello to her, talk to her. She didn't want me there either. I was a psychiatry resident. But eventually I was able to sit there with her. I did a guided imagery with her, as I did with cancer patients with extreme pain. And that she responded to and sort of relaxed a little bit. And then she told me about what her husband had said and how he had told her that. And then she started to cry and said, I never want to think about that again. I want to die, so I never have to think about that again. So for me, the whole case was so upsetting because I knew that there was no way this could be an expression of her longstanding values or anything. She was in a state of extreme hurt reaction. But the medical team immediately, including the ethics person for the hospital, the surgeon, the general internist, who had a great reputation of being a caring person. They were all, I think it's important, able-bodied men, married. The idea that she would now have to adjust to being a wheelchair user without a husband, they thought it made sense how she felt. That this is many years ago, that she didn't have a life if, she'd lost what made her life meaningful. And we had a policy years ago at this hospital that if someone's in extreme pain, you can turn up the morphine. And she was in emotional pain, but she was complaining of pain. And they essentially that evening turned up the morphine and she passed away. So I've written about the case for 30 years.
Mm. A few things that stand out to me that I'd love to hear a little bit more. The first one is a little bit about projection, maybe. So you point out in your paper that there is this danger of how medical teams maybe can exacerbate the situation if the patient's hopelessness evokes similar emotions in them, and we can have this effect upon each other. Um, I'd love to hear a little bit more about your thoughts on that.
Well, you nailed it. Just time wise, I think that's
Yeah.
first of all, she was refusing medical care.
Mhm.
She was refusing dialysis at this point. And it happened, I saw her about 12 hours, and it happened on a Saturday night. I still remember this. They called psychiatry Sunday afternoon. So it was about a 36-hour period where she was refusing the doctors, this caring internist, the surgeon. She was refusing them to come in and talk with her. The ethicist just did a very simple evaluation. I know you're interested in this too, for competence.
Mm.
And she understood the risks and benefits of refusing dialysis, et cetera, and met his criteria for competence. I mean, I think that if she had expressed more ambivalence, the team would have done better. But I think that given her, it was very extreme to be with her. She was in so much distress that, I mean, I had my own emotional reactions to it. I think everybody did. But the model in healthcare, the reason my book is called From Detached Concern to Empathy, and the book is about her, is the model then is we were not supposed to be emotionally affected as doctors. So there was no training at least in general teams. This isn't a palliative care team, which would have been great if they would have called in a palliative care team. Now that I've worked with so many through the years, that was not even in this picture. But for the general medical and surgical team, there was no training in your own emotional reactions, your projections, your unconscious reactions. So none of us were equipped to realize that her distress was shared with us, that we became anxious and afraid and felt helpless. And really, all of us did. And none of us were trained to know how to recognize that or deal with it.
One last comment before we move on to the affective forecasting. So you just mentioned the ethicist explored the risks and the benefits. And to me, it feels like they explored the factual, concrete risks and benefits, not necessarily the emotional piece, which seems to be a really critical part about the benefits. If your emotions are obfuscating your ability to foresee the future, do you really have capacity? And I think that's a part that we deal with quite often. And it was one of my worries when I was reading about your case.
Well, when I read some of your cases that you kindly shared
Mm.
with me, I mean, I think you and well, I think this whole group, I could learn so much from you, Marty, and from others in this group, because it sounds like you've seen these things many times where there's a sudden radical shift towards catastrophic thinking or sometimes wishful thinking. Sometimes suddenly somebody thinks, oh, this will cure me or something when there's no evidence for that.
Mm.
But anyway, when there's a sudden shift, and then you nailed the two things I look for: a very sudden, emotional shift. I mean, this isn't rocket science in the sense that she had a lot of catastrophe happening. I mean, what her husband said to her was emotionally devastating at that moment. But the thing that you said that most people don't talk about, that's my biggest thing, and I was really excited that you have noticed it through your practice, is certainty. When people are just certain there's nothing to live for. And this is someone who the form of art she did wouldn't be affected by her
Mhm.
diabetes. It wasn't even visual art. Her eyesight was fine at that point. She had a very secure circle of friends. I mean, the evidence that she could find reasons to live. This wasn't the kind of person, if she'd gone through a planned divorce over time, couldn't
Mhm.
live without her husband.
Mhm.
From all the evidence from her friends, from years ago, as I remember it. But the certainty she had nothing to live for, sudden certainty that there was nothing to live for, that seemed very problematic to me, and like it should be part of a competency evaluation. So I do have a paper. We did develop a model that the NIH and others use now that came out. I mean, this stuff happened, in I wrote about this in 2001, Ms. G, in the book, my first book. But we published about 5 years ago criteria for including it in in competency evaluations and decision making in palliative and other cares on appreciation. And we called it the appreciation criteria. So we can send you that article. But it's just basically very concrete. Does a patient really appreciate concretely what in the near term their life will be like? Like, can they really describe, if they say there's nobody and there's nothing, is that realistic? Can they describe what's actually going to be like in their life with treatment or without in the next near term? So, but you nailed it.
All right, let's transition. Let's have you pull up your affective forecasting and lay it down on us.
Okay. All right. So I'm going to go quick because I want to get to hear your audience to other things. So there's an article that came out quite a while ago, but the key thing is that affective forecasting is a field in psychology and behavioral economics, an intersection of those two fields that looks at how people predict their lives if they have loss or gains. The first article in the field came out in 1971. It's called Lottery Winners and Accident Victims. And they looked at how people think their life will be if they win the lottery or if they have a serious car accident, and how much they predict their life will be worse or better, and how much their lives actually are after serious losses and gains. Not in healthcare at all. That field is called affective forecasting. It's the heart of behavioral economics and psychology. But we looked at it in healthcare. And we found that there are three types of errors that are common with affective forecasting that we also saw in healthcare. And those errors are focalism, immune neglect, and the inability to imagine adapting. So let me talk about what they are. So this is exactly well, it's not exactly what we're talking about. We were talking about emotional distress. This is really important. This is not emotional distress. We've just changed topics pretty radically. This is about cognitive biases that are built into us, even if we're calm, nothing terrible's happened, or whatever, about how we predict our future well-being under conditions of loss or gain. We're just not realistic predictors. So focalism is if you ask me to picture my life without, let's say I love to swim, and where I have a physical disability where I can't be a swimmer, and that's what I love to do, I might tell you, well, I have nothing to live for, whatever, because I just picture how I won't be swimming. I only picture what I'll lose. So there's a case in our article, which I'll give you the reference to at the end, of a man who is in his late 50s, a policeman who is having, like Ms. G, a second amputation from diabetes. And he won't be able to, he'll be, use a wheelchair, and he won't be able to run around with his grandchildren. And he feels like his life will be over if he can't be physically active. He was a very active man and run around with his grandchildren. So focalism is that's what he pictures. He's not picturing other things in his life. And I'll get to how you can help people picture other things in their life. But that's a big mistake we make. So when again, I want to hear your audience with your clinical experiences, but when people are facing a potential loss, they may narrow in on what they'll lose and not picture the other parts of their life. The second is called, this is from the field, they pick these names, immune neglect. And what they mean is your immunity here is your psychological immunity or your defense mechanisms and coping mechanisms. And what people don't picture is how when they deal with the loss, they'll have all these great immune defense mechanisms that we all have, whether it's humor, whether it's altruism, or whether it's denial, or whether it's compartmentalization. Doctors were great at that. Like, we just do our work and get through our day. And that's not a bad defense, actually, in various ways. And then the third is the most interesting to me, which is much harder to define. And it was not defined in the field yet. I have a book that I've been working on for many years that is looking to make a difference in that, which is to try to imagine how you'll adapt in the long term when you might actually change the person. Your values might change, what matters to you in life might change. And of course, all of us who study elders know that that actually happens just as people age. But when a 55-year-old with a certain cancer, whatever, you folks will tell me about this, is dealing with certain kinds of changes in their life, they may not understand that 5 years from now, or 10, the same things won't matter to them that matter to them today. So that's something we have almost no research on, other than in geriatrics, but from health losses. I'm just gonna, I think I'm gonna skip some of this because it's in the article, but just to show that as of even 2008, these biases were found in all these issues. When people are picturing living as a wheelchair user, when they're picturing living with a visual impairment, when they're picturing living with heart disease, a colostomy, but it had not been studied in palliative care. My co-author on this article was a palliative care physician, and so this was the first article we used cases in palliative care. So basically, there's a lot here, and it'll be good for your audience to see it if they want, if they're interested in the article. But it's all the ways that the model that I think most of you folks use, but you can enlighten me, shared decision making, the patient's expressing their values, and we're helping come to a decision. But the idea is at least about the facts. Ultimately, if it's going well, there should be shared beliefs between the physician and the patient about what the actual medical facts and impact on disability will be. But what was missed there was what people thought were values. So the case that I had there is a woman who had a stroke, who felt that she had a middle cerebral artery stroke, and she felt that because she was aphasic, she couldn't speak at the time, right after the stroke, that her social and active life would never be able to resume. And that's unrealistic for where she was at, because people do regain speech in most cases like hers. And yet she didn't believe that. She thought, forget it, I'll be in the person. There was no certainty. She might not have regained speech, but her emotional state was such that she believed she would definitely not gain speech. And she also overpredicted loss, which we do cognitively. And that looked like in shared decision making, her value was to die, but it wasn't really her value. It was her belief that she could never have a chance of regaining speech, or if she couldn't speak, other ways of having social connections. So physicians might overlook and respect a patient's values in a decision, overlook that they might have some beliefs that have these kind of mistaken certainties. And I talk about communication tools that help with that. The appreciation paper I'll send you, the empathic curiosity, I actually coined that term 30 years ago. It actually wasn't in the literature. And it's my whole career is about empathic curiosity, but just the way you're looking at me right now, Marty, and the way I'm sure all of you listen to your patients, it's about as obvious as breakfast cereal, that's what we all do if we're going to be connecting with patients, is we try to understand their perspective. Um, and hopes and fears is very familiar in oncology, I think. So these are interventions, and then this is more relevant. I'll just blank out for a minute. Um, the last slide has to do with the second part of what we're going to talk about. You're all experts in this clinical areas where folks face very serious losses or potential losses. And my current book project, which I've been working on for over a decade, is related to people in the prime of life, not when they're very elderly, because that's been studied, but not in the prime of life. It hasn't been studied, facing serious health losses, as in cancers and other serious changes. But for folks that are not imminently, which thank God many today are not in a position of very imminent death, but have a lifespan ahead of them with uncertainty, what do you see as the ways that they develop psychological resilience? What do you see as the things that help people adapt, people who were healthy and have a lot of responsibilities, family, jobs, et cetera? They thought they were going to go on like that for a long time, have a serious cancer or other, and have to change their view of their life, but develop an attitude that allows them to be resilient and to live full lives. What are the psychological things that help them? That's my request.
Ah, Becky, you raised your hand.
As we were talking about how people in the prime of life, how they might cope with things and what they might do, immediately I thought a story of a patient that I saw when I was still working in cancer care. He was diagnosed with a form of leukemia. His genetics were really aggressive, indicating a poor prognosis. And we had talked about some of the things that he could do, what the risk benefits were, chances were that it would work. And I was sitting and chatting with him, and he looked at me. He's like, you know, thought about it. I could do all that stuff, but if I'm gonna die anyways, excuse me, he goes, I don't want to be miserable. I want to choose how I leave this world and what I'm gonna do with my time. I spent all of my life working and not doing some of the things that I wanted to do. And you know what? It's time. So he holds up this paper towel that he had been writing on. He's like, I wrote myself a naked bucket list, and I'm going to go and do all of these things. And that's what my life, however much of it I have, is going to look like. And it made him so happy to have come to that decision. And he looked like a completely different person. So I did not see any interesting stories in the news after that, but I am quite certain that this man left and started working on his bucket list.
Wow. Thank you so much, Becky, for sharing that.
Eve, I see that your hand is raised.
Yeah, and kind of continuing on what Becky said. So I'm in hospice, but what's always struck me is hearing people's stories leading up to hospice, and kind of what Becky's saying. I'm always in awe of the younger patients who share with me that when they receive their terminal diagnosis, that sometimes that was the best gift they got in life, because that's when they really started living, because that's when they knew their time was limited. And, I know you spoke earlier that it's hard to not project, right? It's something I try to bring back in my life when I'm having a day that, I think is stressful. And I'm just in awe of how some of the people we work with can take this devastating news and turn it into what they say the biggest gift that they've received.
Thank you. When we have to take in other people, that's empathy. I don't think that that's projection. I think that you are identifying with them, and I think it's fantastic. Thank you.
Um, I have been practicing palliative care inpatient consults for about a decade. And um, when I very first started, I created an advanced directive when I finished fellowship. Why? Because I saw so many horrible things. And I was, worried about enduring suffering, and wanting to make sure that my limits were known. And it was a pretty black and white advanced directive, and I still have not gone back and revised it. But when I was fresh out of fellowship, I felt like my goals of care conversations with my patients then were pretty black and white. I wanted to get at, here's where your line in the sand is, a concrete plan. This is when we're going to enroll in hospice. Let's have it all planned out. And that has changed so much now over the last 10 years. And now I am looking for more gray area. Now I rarely ever will put anything very certain in the chart. Even if somebody is certain with me, I'll say, well, this is at the point where we need to at least have another conversation. Um, and when I do meet people that give me very certain limits, now I consider my job to be there to politely try to poke holes in their argument. Out of love, not not to be a pain in their butt, but it's a lot of, okay, you say you never want to have X. Do you think there's any room that you could be wrong? Do you think that there's something that you could still enjoy? I'm trying to see if there are little areas that I can poke holes in. And I feel like more often than not, I get somebody that pauses. There are some people that, yeah, they know exactly what they want, and so be it. Fair enough. But I feel like there is more people are willing to consider that they might have some room to change.
But a gift, right? That you're giving them as well, because it's so interesting that it makes me so sad that the medical system, we spend so much money on certain things and no money for doctors and patients to have conversations that take time. That's a conversation that probably a lot of people wouldn't even, I think it's incredibly important. I bet it makes your patients feel really valued and respected by you. I can't imagine a conversation like that if somebody really over thinking about it, if they value not going through certain kind of pain or certain kind of procedure, they'll stick with that ultimately.
Mm.
But if there was a way in which they didn't really, this makes me want to cry, but a lot of my work shows that you all tell me, but I do think people, they also don't want to burden their families and other people, and they don't want to be too complicated. And I mean, I just think it opens up the possibilities for people to think about the value they might have as a person.
Mm.
That doesn't mean they have to always accept treatment or anything, but it's very interesting and wonderful.
Mm. We hear that word pretty often, burden. Um, and yet I feel like when I hear that word, it's when a patient shares it one-on-one when family is not there. I feel like more often than not, when I ask, have you talked with your family about that feeling? The answer is no. Um, More often than not, when I talk to the family about it, they feel like it's not a burden. And what is it really? Um, I think a lot of it is helping to facilitate that conversation. What does a burden really mean? Is family, or is this patient worried about something that's not real? Would the family welcome that burden, whatever that is? Maybe that would be something that they would value tremendously. A lot of things are not said, and I think we help to make them be known.
This is quite a wonderful conversation from my end for to learn from all of you. And if people do want to share more things with you in the future that you could send along with me, to me, I really want to learn about. I'm just looking because we have to end in a minute, right? Is that correct?
Do we have
So
to? We don't have to, but
we're talking about endings. But I would love to hear from your group, whatever they want to share, because I feel it's so precious, all of your experiences. You've been with people during the most meaningful times in their lives and the most difficult situations. So please share with me anything that you think would be helpful for people to know about how people develop ways of feeling respected, meaningful, and involved in their lives when they have to deal with so much uncertainty and loss.
All right. Well, thank you, Jody. It was a pleasure.
Thank you all. Thank you, Marty, very much. Thank you.
All right.
Bye-bye.
Be
Bye-bye.
well.